Hi, everyone. My name is Dane Thomas, and I would like to welcome you to APP Virtual Lectures. We have two viewer audiences today, APP to APP and My Catholic Doctor. I'm a medical oncology and hematology physician assistant practicing at Texas Oncology in Dallas, Texas. Today, I'm presenting my lecture, You've Got Anemia. Now what? We will discuss anemia in its entirety, how it's typically presented in clinical practice, how to diagnose it, how to treat it, and how to work with your hematology team to manage anemia in your patients. I'll be discussing real-life case studies of patients I personally have worked up in my career. I truly hope you will find this lecture exciting and educational. I have no disclosures, but I do have a disclaimer. This lecture is intended for informational purposes only. Individuals should use sound clinical judgment when evaluating all patients with hematological issues and err on the side of caution with any patient presenting with a potential life-threatening hematological complaint. The objectives of this presentation are as follows. Number one, we'll discuss how to identify anemia. Number two, we'll discuss the various causes of anemia. Number three, we'll discuss typical laboratory and clinical findings that we see in all types of anemia. Number four, identify treatment options for anemia. And number five, identify when to refer to hematology. What is anemia? This slide is mainly a reference slide, and normal ranges are listed here. Laboratory evaluation for anemia can be straightforward and also could be complex as well. This slide is also used as a reference slide to talk about the breakdown of the complete blood count, also known as CBC, and it explains all the different components and the normal values. This slide demonstrates all the stages of RBC development, from stem cell all the way to red blood cell or erythrocyte. But the most important thing is the reticulocyte cell is right before the formation of erythrocytes. And it is normal for all of us to have some reticulocytes in our peripheral smear, in our bloodstream, but we should not have more than 1.8% of reticulocytes in our blood count. And if there is more than that, we have to suspect there is some sort of hematological issue going on. This slide is another reference slide for this to describe the whole cycle of red blood cells, including the formation and destruction of red blood cells. And we will talk about each of these processes in the upcoming slides. So let's get down right to it. What can cause anemia? We'll first talk about our first case study. A 34-year-old female presents in clinic for anemia. She reports that she has been dealing with anemia since childhood. She was never told the reason of her anemia from a young age. Her anemia was stable until after her pregnancy. She had a vaginal delivery and unfortunately lost a large amount of blood. At that time, her hemoglobin dropped to 6.0. She did not receive a blood transfusion. She then continued to deal with her chronic anemia, but it remained mild. Approximately 6 months ago, she started to experience increasing fatigue. She went to her primary care physician and underwent lab work, which revealed the following. And her lab values are listed here, and I'll outline the abnormal labs in bold. And her hemoglobin, it was measured to be at 10.9, which is low. Her hematocrit was also low at 33.3%. Her MCV was low at 78.8. Her iron saturation was also low at 15%. And her ferritin was suboptimal and low at 33. She was then instructed to take over-the-counter oral iron once a day, which she did for 2 weeks. She was unable to tolerate her oral iron supplement due to constipation, bloating, and gas pains. She was then referred to hematology for further evaluation of her iron deficiency anemia and to be evaluated for IV iron replacement therapy. So what does this patient have? She has iron deficiency anemia. Common causes of iron deficiency are many. First one that's mentioned here is menorrhagia, which can be secondary to uterine fibroids or endometriosis. Gastrointestinal blood loss, which can be secondary to multiple different medical issues, including peptic ulcer disease, arteriovenous malformations or AVMs of the small bowel, ulcerative colitis, bleeding hemorrhoids or anal fissures, Cameron's erosions from hiatal hernia, and last but not least, colon cancer. Genitourinary blood loss can also cause iron deficiency. Malabsorption is another common cause of iron deficiency, and causes of malabsorption include irritable bowel syndrome, or IBS, celiac disease, surgical regions, which include gastric bypass surgery, and chronic proton pump inhibitor use, as well as gastritis and H. pylori infection. And one of the most common causes of iron deficiency in females, besides menorrhagia, is pregnancy. A rare cause of iron deficiency is paroxysmal nocturnal hemoglobinuria, also known as PNH. This can actually cause iron overload at times due to hemolysis in more advanced stages. Typical laboratory findings of iron deficiency anemia include microcytosis, hyperchromia, reactive thrombocytosis, borderline low or high white blood cell count. And when we look at iron studies, we look at three main iron laboratory values: the iron saturation, ferritin, and TIBC. The iron saturation, I like to describe it as the iron that's circulating in your blood that's readily used by your body to make up more red blood cells in your bone marrow. When I talk to patients, I refer to the iron saturation as similar to your checking account. We use our checking account to pay our bills, buy groceries, buy gas, our necessary day-to-day things that we need to purchase. The other iron level that we look at is ferritin. And that's what I like to call your iron reserves or your savings account. So in essence, your body uses the iron in the blood, your iron saturation, to use that to make red blood cells. And anything left over gets stored as ferritin or your iron reserves. So just like in our checking account, anything left over should be put into savings for a rainy day. And our body does the same thing with iron in the form of ferritin. So with iron saturation, if it's less than 20%, we consider that a patient being iron deficient. Severe iron deficiency would demonstrate an iron saturation less than 10%. Ferritin of less than 40 would indicate iron deficiency, and severe iron deficiency would be evident with a ferritin of less than 10. TIBC, or total iron binding capacity, is typically elevated in iron deficiency. TIBC is what I like to describe as empty buckets that your body produces to try to collect iron from your blood. When your body senses that it's got plenty of iron, it's making plenty of red blood cells, it doesn't make as much buckets because it doesn't need to collect as many iron molecules. But when the body senses that it's iron deficient, that it needs more iron, it's going to make more buckets to collect iron in hopes of correcting its anemia. So TIBC is inversely related to your iron status. So if you have low iron, you have high TIBC, and vice versa. And in rare cases, we also check an elevated soluble transferrin receptor, or transferrin, and these values are elevated just like TIBC. And we do this because check these values because some patients who have chronic inflammatory conditions can have an falsely elevated ferritin because ferritin is also an acute phase reactant. So when we have patients who have elevated ferritin levels, but also have low iron saturation, we check a transferrin or soluble transferrin receptor panel to see if that's elevated to confirm whether they truly have iron deficiency or not. Clinical findings of iron deficiency are numerous and are mentioned here. They include fatigue, lethargy, skin pallor, brittle, spoon-shaped fingernails, hair loss, brain fog or short-term memory loss, shortness of breath on exertion, dizziness and lightheadedness, headaches, and the good old pica, which can include eating or chewing ice, dirt, uncooked rice, chalk, and other things, restless legs, and muscle cramping, and tachycardia. Treatment options for iron deficiency really come down to oral supplementation and IV iron supplementation. So let's talk about oral supplementation first. Let's also talk about pros and cons. So the pros of oral iron supplementation, it's extremely convenient for the patient, very cost effective, and not time consuming. The cons, unfortunately, most patients cannot tolerate oral iron due to side effects, which can include constipation, upset stomach, diarrhea, and nausea and vomiting. It's also not effective for severe iron deficiency or iron deficiency secondary to malabsorption. Comparing formulations of oral iron supplementation can be undaunting because there's so many different formulations out there. But all in all, based on current studies, all of these formulations are pretty much equally effective. So you can't go wrong with most of them. Polysaccharide iron complex and heme iron are more expensive but lack metallic taste. You should avoid enteric-coated or sustained release capsules due to the fact that it is typically poorly absorbed due to iron released too far distally in the intestinal tract with these sustained released iron supplements. How what we recommend patients to take and how to take the iron supplements is we recommend several things to do. The first one is that we recommend patients to take their oral iron supplement with vitamin C, which can possibly improve absorption. So I typically advise patients to take the iron supplement with a glass of orange juice or an orange or with a vitamin C tablet. We also recommend avoiding taking the iron supplement with food. And we also recommend patients to take their iron supplement 2 hours before or 4 hours after ingestion of any antacids. Iron infusions is the other option. And let's talk about first the pros and cons. So the pros, side effects are typically rare. They include nausea, diarrhea, headaches, muscle cramping, joint pain for 1 or 2 days after the infusion. It's effective for patients with malabsorption. There's no need for daily consumption of oral iron. And it's very effective for severe iron deficiency. The cons, it's not, unfortunately, not cost effective. It's time consuming and typically requires patients to take time off from work. There's a higher chance of infusion reaction for patients with autoimmune disorders. With iron infusions, studies have shown that there's no evidence that a dose above 1,000 milligrams of elemental iron is clinically useful. I typically don't give patients above 1,000 milligrams in one round of infusions because of this fact, and as well as to prevent iron overload, which can cause a whole slew of side effects. The only exception that I make in giving no more than 1,000 milligrams is for patients who have severe ongoing blood loss that you know that it's not going to get resolved in the near future. So in those cases, I typically give more than 1,000 milligrams, and hopefully those patients will resolve the underlying issue. Intramuscular iron is an option, but it can raise their iron level, but the route of administration is typically painful, and there's a chance of skin staining, and the absorption is variable. Transdermal iron, unfortunately, has no clinical evidence of effectiveness or safety thus far in humans. So we don't typically recommend that to our patients. So typical responses to iron supplementation is important, and we try to counsel our patients for them to have proper expectations. So pica symptoms typically disappears pretty quickly, almost as soon as oral iron IV iron therapy has begun. Restless legs tend to have complete or near complete relief within 72 hours of IV iron. The patient's hemoglobin will rise slowly, keyword slowly, starting 1 or 2 weeks of treatment. The hemoglobin will rise approximately 2 grams per deciliter over the next 3 weeks. The hemoglobin deficit typically is halved in approximately 4 weeks. And then the hemoglobin level will normalize by 6 to 8 weeks, or longer in some patients. So when approaching treatment options with patients, it can be difficult, and there are several factors you want to take into when trying to treat your patients with iron deficiency. So if you have a patient with iron deficiency associated with no ongoing blood loss or the etiology of the iron deficiency secondary to malabsorption, you want to try oral iron supplementation with either having them take an iron supplement once a day, or 1 tablet every other day, or 1 tablet twice a day with vitamin C for 3 months. And then after those 3 months, recheck their labs to see if there's any improvement. If there is no improvement, then you should refer to hematology for consideration of IV iron. If the patient's iron deficiency is associated with ongoing blood loss, then we want to look at how severe the iron deficiency is. If it's mild, try oral iron first as above, and if it's severe, go ahead and refer to hematology for IV iron. So let's go back to that first case study. So she reports that her menstrual cycles are regular and currently last 7 days. Previously, her periods were only lasting 5 days. She goes through 1 pad every 2 to 3 hours for the first 4 days of her menstrual cycle. She received 4 Venofer 200 milligram iron infusions, which made her feel so much better. Her labs after her infusions reveal a hemoglobin of 12.6, a hematocrit of 38.2%, a ferritin of 80, an iron saturation of 29%. So all in all, much better values. She then followed up with her gynecologist and was started on oral birth control, which helped lighten her menstrual cycles and therefore resolved her iron deficiency. There are many patients that are on anticoagulation, either on short-term or long-term, and it's important to also think about iron deficiency in these patients. So patients on chronic anticoagulation can have an increased risk of developing iron deficiency. With patients with warfarin have a 3.8% rate of hospitalization for uncontrolled bleeding, and this is in a subset of patients greater than at the age of 66. Lowering INR typically does not decrease the risk of bleeding with these patients, unfortunately. Patients who are on DOACs, which are also known, which include Eliquis and Xarelto, they have a lower risk of bleeding, 0.8%. but the increasing dose of these anticoagulants correlates with the increasing bleeding risk. So you have to be careful with these strong blood thinners. Recently, in June 2023, there was a new analysis that came out of a randomized trial in older adults who were assigned to daily low-dose aspirin or to a placebo. The study documented a small but statistically significant increase in the rate of anemia, 51 per 1,000 person in the aspirin group versus 43 per 1,000 person with placebo. An iron deficiency in 13% of patients with aspirin use versus 10% with placebo use. Although this doesn't sound dramatic or huge, I would recommend, based off of this study, to throw in an iron panel with your patients on chronic anticoagulation at least once a year to monitor for iron deficiency and treat if needed, because they are going to be slightly higher at risk. So let's talk about another case study. A 51-year-old female presents for recently diagnosed iron deficiency anemia. She reports that she has had decreasing energy levels for the past several years. Most recently, she has been dealing with intermittent chest pain for the past few months. She underwent cardiac workup, which was negative. She was diagnosed with iron deficiency anemia earlier this year. She started on oral iron supplementation for approximately 6 months, but stopped due to constipation. She underwent lab work, which revealed the following. She had ferritin of 15, which is low, and iron saturation of 10%, which is low, and the rest of her values were normal as listed here. Her past medical history is significant for gastric sleeve surgery and hiatal hernia repair performed 5 years ago. She unfortunately had her hiatal hernia repair with worsening of her reflux. She then underwent gastric bypass surgery in 2019 and surgical repair of her hiatal hernia. She has seen GI in the past and underwent her last EGD in April of 2021, which was only remarkable for GERD. She underwent a colonoscopy in September of 2020, which was normal. She continues to take her oral B12 supplement on a daily basis for her B12 deficiency. She was seen by us and we administered 2 ferrium infusions, which she tolerated well. We performed follow-up labs, which revealed much improved values as listed below here. Her iron deficiency was secondary to malabsorption. So let's talk about malabsorption syndromes. So iron is absorbed maximally in the duodenum of your body. Your B12 and folate is absorbed in the GI tract via a complex mechanism in the stomach, duodenum, jejunum, and ileum. Common causes of malabsorption syndromes typically are from disorders affecting the mucosal cells responsible for iron absorption. Bariatric surgery is a big cause of this, just like with this most recent case study. And bariatric surgery can include gastric bypass, gastric sleeve surgery, duodenal switch, and lap band procedures. Celiac disease can also cause malabsorption, as well as atrophic or autoimmune gastritis, H. pylori infections, as well as chronic use of proton pump inhibitor use. Now, why does chronic use of proton pump inhibitors like Prilosec and Nexium cause iron deficiency? Iron and folate need an acidic environment to be absorbed through your intestinal tract. So if you're taking chronic PPIs, that acidity is not going to be there. And unfortunately, because of that, the absorption of iron and folate is going to be diminished. And last but not least, irritable bowel syndrome has been shown to cause iron deficiency as well. Now, in speaking of weight loss surgery and gastric bypass surgery, we want to just take a minute to look at the anatomy here. And on the left side here is the normal parts of your stomach. And the middle and right side of the slide here talks about the two different types of weight loss surgeries, which include Roux-en-Y gastric bypass and sleeve gastrectomy. So this is for you to review. And as you can see, with these two surgeries, we cut out the area where the body can absorb these vitamins. Now, anemia, that's secondary to malabsorption syndromes, is quite common in our practice. And we first will talk about iron deficiency. And unfortunately, iron deficiency secondary to malabsorption may not respond to oral iron supplementation, or patients, because of their malabsorption issue, don't have a great tolerance to it. These patients likely will need IV iron replacement therapy lifelong if found to have iron deficiency. On average, patients receive IV iron in this setting from malabsorption every 12 to 18 months from my experience. The average time from bariatric surgery to the need of iron replacement therapy varies, but on average is about 5 years. About 50% of patients with malabsorption to iron will also have B12 and folate deficiencies. Fortunately, it's rare that B12 injections are needed in these patients, and oftentimes oral B12 supplementation, either through tablets or sublingual, are very effective in raising B12 levels. Let's talk about another case study. A 67-year-old female with a past medical history significant for gastric sleeve surgery in 2015 presents with extreme fatigue, increased mental fogginess, and cravings to eat various types of foods for the past year. She has never been diagnosed with iron deficiency anemia or thrombocytosis in the past. She underwent lab work with her endocrinologist, which revealed the following. And as you can see, her hemoglobin and hematocrit are low, her MCV is low, her platelet count is extremely high at 570,000. Her ferritin and iron saturation are extremely low with a ferritin of 5 and iron saturation of 7%. She was evaluated by us and we gave her 2 ferriheme iron infusions, which she tolerated very well. We performed follow-up labs at her 2-month follow-up visit with us, which revealed improved hemoglobin and hematocrit levels, but they remained low at 9.7 and 30.5 respectively. Her platelet count went down to 445,000, but it was still elevated. And as you can see, the ferritin significantly improved to 121, and her iron saturation did improve, but it was still suboptimal at 17%. Also, at her 2-month follow-up visit, we checked a hemocold stool, which unfortunately was positive ×3. She was immediately referred to GI due to the positive hemocold stool cards and underwent an EGD and colonoscopy, which revealed gastritis, LA grade A esophagitis in the gastroesophageal junction, gastric sleeve anatomy, and unfortunately a sigmoid colon mass which was biopsied. 1 polyp in the cecum and 1 polyp in the transverse colon. Biopsy of the sigmoid mass was positive for adenocarcinoma. And this picture here demonstrates her actual sigmoid colon mass right over here. She underwent a robot-assisted sigmoid colectomy with low pelvic anastomosis. Pathology from her surgery reveals moderately differentiated colonic adenocarcinoma extending entirely through the colonic wall and into the pericolonic adipose tissue. Her stage was stage 2A, T3N0, C, M0. Next case study involves a 27-year-old female with a past medical history significant for chronic constipation since birth. Presents with a new diagnosed iron deficiency, anemia. She reports that she has never been diagnosed with anemia in the past. Starting about 3 months ago, she noticed that she was feeling more fatigued and short of breath. She followed up with her PCP to complain of these new symptoms and underwent lab work, which revealed the following. And as you can see in the bold, she presented with severe anemia with a hemoglobin of 6.8, hematocrit at 24.2, MCV of 55.5, MCH of 15.7, and MCHC of 20.2. She was instructed by her PCP to take one oral iron tablet daily to seek hematology consultation right away. She also complained to her PCP of rectal bleeding for the previous 6 months. She reports that she sees blood on her toilet paper after wiping occasionally. She was referred to GI by her PCP for further evaluation. She was seen by GI in the past for chronic constipation workup, and no etiology was found. She has never undergone any scalp examinations with GI in the past. Her menstrual cycles upon her consultation visit were non-existent due to having an IUD. She received one ferriheme iron infusion, but suffered an infusion reaction, unfortunately, with her second ferriheme infusion. She then received 2 Lennifer infusions, which she tolerated well without any issues. She was seen by GI and underwent an EGD and colonoscopy, which revealed grade 3 esophagitis in the lower third of the esophagus, medium-sized hiatal hernia, localized ulcerations and erosions of the mucosa with no bleeding in the pre-pyloric region and antrum, and unfortunately, a mass in the sigmoid colon located 20 centimeters from the rectum. Biopsy of this mass was positive for tubular adenoma with high-grade dysplasia. She then underwent a robot-assisted laparoscopic low anterior colon resection. Pathology revealed moderately differentiated colon adenocarcinoma, inviting entirely through the colonic wall into the subserosal connective tissue, with 0 out of 41 lymph nodes positive for metastatic disease. So her staging was 2A PT3 N0M0 moderately differentiated adenocarcinoma of the colon. So with these past 2 case studies, we, just like with them and many patients with iron deficiency, we find that these patients have, unfortunately, colon cancer. So let's talk about colon cancer. It's presented in about 150,000 cases in the US annually. Unfortunately, 20% of these cases have distant metastatic disease at the time of presentation. So common symptoms and signs of colon cancer include hematochezia or melena, abdominal pain, unexplained iron deficiency anemia, and very important, a hallmark with iron deficiency in males is that you must rule out colon cancer. And last but not least, change in bowel habits. Testing includes the colonoscopy, which is the most accurate and versatile diagnostic test. Fecal immunochemical test for occult blood or FIT testing is also a good option. It was 97% sensitive in one meta-analysis. Flexible sigmoidoscopy is not recommended due to a shift in right-sided approximal colon cancers in the past 50 years. Screening for colon cancer is very important. The U.S. Preventative Services Task Force, otherwise I'd like to call this task force as UpStuff, recommends initiating screening at age 45 instead of 50 now, and at the end screening at the age of 75. Colonoscopy should be performed every 10 years or sooner after the first colonoscopy if colon polyps are removed. FIT testing for occult blood can be done annually instead of the colonoscopy if the patient is unwilling or unable to have a colonoscopy. Now, the newest testing for colon cancer screening, as you might have heard, is Cologuard, or multi-target stool DNA testing. It combines fecal markers for hemoglobin and DNA mutation and methylation. UpStuff recommends using Cologuard screening every 1 to 3 years. Unfortunately, it is more expensive than fit testing, but it's becoming more and more widely accepted and used in clinical practice. And lastly, computed tomography, colonography, or virtual colonoscopy can also be used as an option. And this is recommended to be performed every 5 years. So let's talk about another case study. A 60-year-old female presents with recently diagnosed iron deficiency anemia. She reports that she was hospitalized for pancreatitis and was found to have iron deficiency anemia. She was instructed to take oral iron supplementation twice a day at that time. Despite her oral iron supplementation, her hemoglobin and hematocrit continued to be below normal on routine follow-up labs with her PCP. Lab work that was done at her PCP's office 4 months ago revealed the following: and low hemoglobin of 11.1 and suboptimal hematocrit of 33.8%. Labs that were done 3 months later revealed continued low hemoglobin of 11.4 and suboptimal hematocrit of 34.2%. She has also been following GI, who has been seeing her for her chronic diarrhea symptoms as well as for her iron deficiency. Patient reports that she's been dealing with chronic diarrhea for the past 20 years with no known etiology. Her last colonoscopy was performed 5 years ago. Her last EGD was performed 4 years ago and revealed mild chronic gastritis, funded gland gastric polyps, mild chronic inflammation, reactive epithelial changes, and negative for interstitial metaplasia. Patient reports that she has never underwent a pill endoscopy in the past. At consultation, she reports that she has been feeling very fatigued and occasionally dizziness with postural changes. She then underwent a follow-up colonoscopy after her consultation visit with us, which revealed 2 polyps, but no evidence of acute bleeding. She underwent the follow-up labs at our office, which revealed continued anemia with a hemoglobin of 11.1 and a hematocrit of 33.9. But now her iron saturation is down with an iron saturation of 8% and an elevated TIBC of 429. She then received 5 Venofer 200 milligram infusions, which she tolerated very well without any issues. She then followed with her GI physician and underwent a pill endoscopy, which revealed multiple areas of focal angiectasias in the small bowel, most prominent in the distal small bowel. Occasionally, we encounter patients with chronic AVMs of the small bowel, especially patients that are above 60 years of age. And we, as part of our workup to rule out iron deficiency, we recommend for these patients to also undergo a pill endoscopy if their EGD and colonoscopy are negative to rule this out. We commonly find this in patients that are older and are also on anticoagulation with either aspirin or some of the stronger blood thinners. And these patients will chronically need iron supplementation for the rest of their lives. And this picture here is for your reference in describing what an AVM is and how it looks like. And of course, I would be remiss to not talk about iron deficiency in pregnancy. So pregnancy commonly causes physiologic or dilutional anemia. And the way this happens is that maternal red cell mass increases, but at the same time, plasma volume increases to a greater degree. This causes hemoglobin and hematocrit levels to decrease to anemia levels. So therefore, normal hemoglobin ranges in pregnancy is different from a person who is not pregnant. During the first trimester, the goal of their hemoglobin is to be greater than or equal to 11. And in the second and third trimester, the patient's goal is to have a hemoglobin of greater than or equal to 10.5. Iron deficiency is a very common cause of anemia in pregnancy. Treatment of iron deficiency in pregnancy includes, and it's very broken down by trimester. In the first trimester, oral iron supplementation is best to use every other day to reduce gastrointestinal effects. And ferrous sulfate is most commonly used in pregnancy. IV iron is definitely contraindicated due to no safety data for first trimester use. In second and third trimester, patients can continue taking oral iron supplementation as above. If the patient has evidence of oral iron failure, they can receive IV iron during these trimesters. And Venofer is the only approved product that is deemed safe to administer for pregnant patients. We definitely avoid Fairlicet for these patients because it contains benzyl alcohol as a preservative. And IV iron is best to use from week 30 onwards due to insufficient time to replete iron orally. So if you have a patient that's 30 weeks and onward in their pregnancy and they have iron deficiency, it's most effective to do iron infusions at that time instead of oral iron supplementation. It's important to note that you want to try to avoid IV iron in late third trimester to avoid risk of inducing labor. And one of the ways that you can induce labor is infusion reactions. With anemia, you also want to rule out other causes of anemia, which can include folate deficiency as well as B12 deficiency, and not just focus on iron deficiency. Now, with iron deficiency, I'm passionate about treating the iron deficiency, but just as important is treating the root cause of iron deficiency, because these patients are going to continue to have iron deficiency unless their root cause is treated, if it's treatable. One of the things that I recommend for providers to do as a routine, if they find iron deficiency in their patients, is to order a fecal occult blood test, which is an easy test to rule out GI blood loss. And if it's positive, refer to GI. And next, we want to use our other colleagues to help treat the root cause of iron deficiency, depending upon what the cause is. And that could include your GI colleagues, your gynecologists, and your colorectal surgeons, because they can perform further evaluation, which can include EGD, colonoscopy, pill-cum endoscopy, can surgically treat large hiatal hernia, can prescribe PPIs for gastric bleeding if it is found, hemorrhoid banding or hemorrhoidectomy for bleeding hemorrhoids, and menorrhagia can be treated in multiple different ways, which include oral contraceptives, tranexamic acid, or gonadotropin releasing hormone antagonists, which one example is mifembree, uterine ablation, and partial or total hysterectomy. So let's steer clear from iron deficiency and let's talk about something else. So the next case study is a 64-year-old male who presents for recently diagnosed microcytic hyperchromic anemia. He reports that he has been anemic for the past 3 years. For those 3 years, he has been taking one oral iron tablet daily, which he has tolerated well without any issues. He recently followed up with his PCP and underwent lab work, which revealed the following. And as you can see, he's got microcytic hyperchromic anemia with these indices. He was then referred to hematology for further evaluation of his microcytic hyperchromic anemia. His past medical history is significant for an abnormal colon polyp and underwent colon resection approximately 20 years ago. He does not recall the pathology of his abnormal polyp. He unfortunately did not need additional treatment. He underwent follow-up colonoscopies with his GI physician frequently, which were eventually spread out to every 3 to 5 years. He also underwent an EGD in the past, which revealed gastritis. He recently saw his GI physician for follow-up, and he underwent a follow-up EGD and colonoscopy, which revealed gastritis, one polyp in the transverse colon, one polyp in the sigmoid colon, and internal and external hemorrhoids. When we saw him for consultation, we ordered an alpha globulin DNA analysis, laboratory testing, which revealed that he has homozygous positive, that he was homozygous positive for the alpha plus thalassemia mutation. So therefore, he has alpha thalassemia. We initiated folic acid, 1 milligram daily, and we had instructed him to stop taking his oral iron supplement because his iron studies were normal and were at goal. So thalassemia is rare, but it's important to note. And this slide here, which continues to the next slide, is here for you as a reference slide to talk about the different breakdowns of alpha and beta thalassemia. But I won't go into too much detail with this, but you can always refer back to this for more specifics on each type of thalassemia. And this slide talks about beta thalassemia on top, but I do want to focus on the management of thalassemia, and which include folic acid supplementation for all individuals with thalassemia major or thalassemia intermedia with evidence of chronic hemolysis with folic acid 1 milligram daily. We suggest this because it compensates for increased folate requirements associated with increased red blood cell turnover. In pregnancy, we actually suggest higher doses of folic acid supplementation between 4 to 5 milligrams a day only during pregnancy. There is a common misconception with thalassemia patients with the fact that they need to absolutely avoid iron supplementation, which is not true. You do need to avoid iron supplementation because there is increased iron absorption with thalassemia, which can lead to iron overload, unless they have documented iron deficiency. If they have a low ferritin, low iron saturation, please feel free to give iron supplementation with oral iron or IV iron. I've done it in the past, and they've done amazing. It will not improve their or correct their microcytic hyperchromic indices, but the patients will feel better and their general anemia will slightly improve. And this is a reference slide for the alpha and beta proteins in the hemoglobin molecule for you to review. And this slide is another reference slide to look at the comparison between a normal peripheral blood smear on the left, and on the right side, a peripheral blood smear of someone with beta thalassemia intermedia. And as you can see, there's a marked difference between the two in the way that the red blood cells are shaped and how they look. The next case study involves a 60-year-old female who presents with recently diagnosed normocytic normochromic anemia. She has stage 4 kidney disease with an eGFR of 13. She underwent lab work at her nephrologist's office, which revealed the following: normocytic normochromic anemia with a hemoglobin 9.6 and hematocrit 29.5, and an eGFR of 14 with elevated BUN and creatinine. We ordered a full peripheral laboratory anemia workup, which was only remarkable for vitamin B12 deficiency. Thus, it was confirmed that her anemia was secondary to anemia of chronic kidney disease and vitamin B12 deficiency. We initiated Retacrit and B12 injections for her. Her hemoglobin improved dramatically to as high as 11.4. This slide is a reference slide to talk about what erythropoietin is and the mechanism behind it, and how it relates to the production of red blood cells. So if you look here, when there is a hypoxic state in the body, there is reduced oxygen in the blood. The kidneys identify that and releases a hormone called erythropoietin, which stimulates the bone marrow to make more red blood cells, and therefore there is more red blood cells in the circulating blood, which can correct and improve the oxygen levels in the body. So let's talk about anemia and chronic kidney disease. So in chronic kidney disease stages 3 to 5, which means a patient having an eGFR of 59 and under. These patients can have anemia, which typically is normocytic and normochromic in nature, secondary to decreased production of erythropoietin due to the fact that their kidneys are not functioning well. A workup of a patient with anemia in chronic kidney disease requires a hematology referral so that we can rule out other potential causes of their anemia before confirming that the anemia is secondary to the patient's kidney disease alone. Treatment for this consists of erythropoiesis stimulating agents, also known as ESA. Examples of these agents include Procrit, Retacrit, as used in the case study before, and Aranesp. Side effects of these agents include hypertension and increased risk of clotting. Relative, not absolute contraindications include a history of CVA, patient with bedbound status, and dementia. Now, if the patient is adequately anticoagulated, their contraindication is virtually non-existent and they can proceed with ESA therapy. So requirements for initiation of ESA therapy at most institutions, and in order for most insurance providers to approve these agents, the patient has to have a hemoglobin and hematocrit less than 10 and 30 respectively, as well as their ferritin be above 100 and their iron saturation be above 20%. After they initiate ESA therapy, they can receive these agents if their hemoglobin and hematocrit is less than 11 and 30 respectively, and their iron studies continue to be at goal. When patients have kidney failure or end-stage renal disease, ESA therapy is taken over by the nephrologist and is administered during the dialysis. Iron deficiency plays a role with ESA therapy because these patients can develop functional iron deficiency while receiving these agents. Their iron stores may be available, but their release into the circulation may not be rapid enough to support the increased erythropoietic rate that is being caused by receiving these injections. If the patient is found to have an iron saturation of less than 30%, it is recommended to supplement these patients with PO or IV iron. So B12 and folate deficiency is commonly found in patients with anemia and patients who don't have anemia. And with B12 deficiency, the textbook definition is a B12 level below 300. But in clinical practice, we consider a level below 500 low. Causes of B12 deficiency are numerous and include IBS, celiac disease, gastric bypass surgery, and medications which include metformins, proton pump inhibitors, H2 receptor blockers, and antacids. Typical findings on CBC reveal macrocytic anemia, and you also want to rule out with macrocytic anemia other potential causes which are listed here, but patients can also have normocytic normochromic anemia. These patients also may have an elevated methylmalonic acid and homocysteine levels. Treatment for these patients include oral vitamin B12 supplementation with vitamin B12 1000 microgram tablet or sublingual daily. And patients with suspected malabsorption issues, we typically recommend sublingual route instead of tablet for better absorption. If these patients do not respond to oral B12 supplementation, we recommend B12 injections by administering B12 1000 microgram intramuscular injections weekly for 4 weeks, then once a month. Intranasal B12 supplementation is generally not used, and transdermal route has not been validated clinically. Pernicious anemia is rare but can cause B12 deficiency, and it's an autoimmune condition that's diagnosed by testing for autoantibodies to intrinsic factor. Folate deficiency is defined as a folic acid or folate level below 4 nanograms per milliliter. And treatment is supplementation with oral folic acid 1 milligram daily. And common medications that can cause folate deficiency include methotrexate, Bactrim, phenytoin, valproate, and carbamazepine. And this is a reference site to look at the comparison between a normal peripheral blood smear on the left and a peripheral blood smear with a patient with B12 or folate deficiency. And as you can see, the red blood cells are misformed and a hypersegmented neutrophil is located here, and as well as macroalveolocytes are here. This next case study talks about a 53-year-old female who presents for normocytic pneumococcal anemia. She reports that approximately 8 to 9 years ago, she was diagnosed with anemia. She was told to start taking oral iron tablets, which she did for the past 5 to 6 years. Around 3 to 4 years ago, she developed menorrhagia with irregular periods, which lasted anywhere from a few days to 1 month. She recently followed up with her PCP and underwent lab work, which revealed normocytic pneumococcal anemia, as listed here. She reports that she most recently underwent a colonoscopy approximately 1 year ago and was told that it was normal. She reports that at her consultation visit, of having unintentional 5-pound weight loss in the past 3 months. She complains of chronic neck and shoulder pain. She underwent a full anemia laboratory workup, which revealed monoclonal IgG lambda light chain disease. She underwent a bone survey, which revealed sclerotic lesions over the iliac wings favored to represent bone islands, and no lytic lesions were identified elsewhere. She also underwent a 24-hour UPEP, which revealed a paraprotein band in the beta region, positive Bence-Jones protein. She then underwent a bone marrow biopsy, which unfortunately revealed about 10 to 15% lambda-restricted plasma cell neoplasm. So unfortunately, this patient was diagnosed with multiple myeloma. And multiple myeloma is defined as a neoplastic proliferation of plasma cells producing a monoclonal immunoglobulin. Proliferation of plasma cells in the bone marrow can result in osteolytic lesions, osteopenia, and/or pathological fractures, which sometimes patients can present in clinic with these findings. Epidemiology, it's not very common. It's about 34,000 cases and 13,000 deaths in the US every year. And worldwide, it causes 180,000 cases and 117 deaths yearly. Clinical presentation includes bone pain with lytic lesions on skeletal films, increased total serum protein concentration and/or the presence of monoclonal protein in the urine or serum, unexplained anemia, hypercalcemia, and acute kidney failure. Prognosis of these patients is not curable, but treatable with multiple modalities that we use in our office. So this patient underwent a bone marrow biopsy, and I wanted to spend a minute talking about bone marrow biopsy and what it entails. And there are multiple indications for bone marrow biopsy, which are listed here. And relative contraindications for bone marrow biopsy include presence of severe hemophilia, bleeding disorders, and platelet count less than 20,000. But again, this is relative contraindications, not absolute. We can work around these contraindications to get the patient a bone marrow biopsy. The location is over here, and it's where this arrow is pointed. The preferred location is the posterior superior iliac crest, but we can also use the anterior iliac crest if the access to the posterior iliac crest is limited. Typically, patients are pre-medicated with local anesthesia with 1 to 2% lidocaine, but if this is performed in the hospital and not in an outpatient setting, they are given twilight anesthesia. Post-procedure complications are extremely rare and can include bleeding, infection, transient lower extremity weakness, and pain. Anemia can be also secondary to other malignancies. Myelodysplastic syndrome, or MDS, and acute myeloid leukemia, or AML, can be demonstrated with a normocytic or macrocytic anemia, which macrocytosis is most common. Also can exhibit leukopenia on their CBC. Prior exposure to chemotherapy agents increases their chances of getting this type of blood cancer. Chronic lymphocytic leukemia, or CLL, can show up as neutropenia, lymphocytosis, anemia, and thrombocytopenia. There is an increased incidence of autoimmune hemolytic anemia in these patients, which can result in a positive direct Coombs test. Chronic myelogenous leukemia, or CML, can present as anemia, leukocytosis, thrombocytosis, and splenomegaly. Colon cancer, as mentioned before, renal cell carcinoma can present as normocytic or microcytic anemia and hematuria. And generally speaking, solid tumors can produce anemia by involvement of the bone marrow space with metastases, typically in much advanced stages of the malignancy. Now let's talk about anemia secondary to hemolysis. So there are multiple causes of hemolysis that can cause anemia, and these include acquired causes, which include cirrhosis of the liver, hypersplenism, infections, and toxins. It also could be hereditary with sickle cell disease, thalassemia, and G6PD deficiency. It also could be result from immune-related processes, from ingestion of certain drugs, hemolytic transfusion reactions, and autoimmune hemolytic anemia. And lastly, as mentioned previously, paroxysmal nocturnal hemoglobinuria can cause hemolysis as well. Signs or symptoms of hemolysis include dark urine, jaundice, gallstones, and anemia with certain foods or drug exposures such as fava beans and oxidant drugs. Labs of these patients with hemolysis include an increased LDH, an increased indirect bilirubin, decreased haptoglobin, a positive direct Coombs test, a peripheral blood smear with positive spherocytic red blood cells, schistocytes, and bite cells. Treatment of these patients include a blood transfusion if their hemoglobin is less than 6, and treating the offending agent, and of course, consulting hematology. And this is a slide that, again, is comparing normal peripheral blood smear, but comparing to a person with a blood smear showing hemolysis due to Clostridium perfringens sepsis. And as you can see these ghost cells here that are indicative of hemolysis, as well as these other abnormal red blood cells indicated here. Anemia can also be secondary to certain autoimmune disorders. The mechanism of action of this type of anemia is similar to anemia of chronic disease or chronic kidney disease. So with systemic lupus erythematosus, patients can have mild normocytic and normocovering anemia, leukopenia, and thrombocytopenia. In rheumatoid arthritis, it is very common for patients to have anemia prior to diagnosis and treatment of rheumatoid arthritis. Fortunately, their anemia typically resolves after treatment with DMARDs. Some medications used for rheumatoid arthritis can also induce anemia, which include methotrexate, sulfasalazine, leflunomide, and azathioprine, cyclophosphamide, as well as NSAIDs and glucocorticoids, which can cause GI bleeding, which therefore can result in iron deficiency. Scleroderma may reveal anemia due to malabsorption, iron deficiency, or gastrointestinal blood loss, depending on which organ is involved. Polymyalgia rheumatica can cause normocytic anemia, and giant cell arteritis can cause normocytic anemia, and usually it's profound anemia, often present and improves after the initiation of glucocorticoids. These patients may also have a reactive thrombocytosis. So last case study is one of my favorite case studies and one of my unforgettable patients. She is a 35-year-old female who presents with recently diagnosed iron deficiency anemia. She states that she has been diagnosed with iron deficiency anemia in the past, most notably during her pregnancy, approximately 4 years ago. She took iron pills during that time and her anemia improved, although she suffered from significant constipation issues. After her pregnancy, she was found to have continued iron deficiency anemia. She continued to take iron pills for some time, but discontinued them due to constipation issues. Approximately 1 month ago, she started to notice that she was developing fatigue, dizziness, and lightheadedness, which progressively got worse over the following several weeks. She reports having a short syncopal episode for 1 or 2 seconds, but regained consciousness quickly. She was then evaluated at her urgent care approximately 2 weeks ago and was found to have a UTI. She was treated with antibiotics and her UTI was resolved. She underwent lab work at her urgent care, which revealed the following. And as you can see in the bold, she had pretty severe microcytic anemia with a hemoglobin of 8.2, hematocrit of 25.3, an MCV of 71.6, with a reactive thrombocytosis, with a platelet count of 450,000, and an elevated white blood cell count of 12.1, and an iron saturation of 5%. She also reports of having unintentional weight loss of 20 pounds over the past year. Her menstrual cycles have, for the most part, been regular. Her menstrual cycle has normal flow lasting 2 to 3 days, and she goes through 3 pads per day. She was then referred to hematology for evaluation for iron infusions. We first did a full anemia workup, which revealed the following on the left side of this slide here. And it confirmed the continued elevated white blood cell count and continued microcytic anemia and reactive thrombocytosis, which actually is higher than what it was previously. And her iron saturation remained low at 9%, but her ferritin was elevated at 219. We also performed the urinalysis, which revealed microscopic hematuria. At this point, due to her elevated ferritin levels as well as elevated we actually performed further testing, which revealed that it was largely unremarkable except for elevated IgG and IgA values, which are listed here on the right. Due to her elevated ferritin levels as well as her elevated IgG and IgA levels, we performed a full rheumatological workup. So her full rheumatological workup was negative, except for she had an elevated sedimentation rate of 86 and a C-reactive protein of 3.4. At this point, I had no clue what was going on. I was stumped. So I decided to perform a malignancy workup due to her weight loss of 20 pounds over the past year that was unintentional. So I ordered a chest x-ray and a CT scan of the abdomen and pelvis with IV and PO contrast. And the chest x-ray revealed no abnormalities, but her CT revealed that her right kidney was asymmetrically enlarged with severe hydronephrosis, calcial dilatation, and extensive uroepithelial thickening and inflammation to the level of an impacted stone at the right uterovesicular junction measuring 10 millimeters. She also had numerous parenchymal fluid collections present in the right kidney, measuring up to 3.6 by 3.5 centimeters. So her diagnosis was xanthogranulomatosis, chronic obstructive pyelonephritis of the right kidney with hydronephrosis and associated pyelourethritis. Now that is a mouthful. So we decided to refer to urology ASAP, and she was evaluated right away. And due to her high risk of kidney atrophy and destruction, she underwent a right nephrectomy. After her nephrectomy, her anemia was completely resolved. And this next slide shows you in gross examination of a kidney with xanthogranulomatosis, xanthogranulomatosis pyelonephritis. On the right, it's a presentation of pyelonephritis seen on CT. Now, this is extremely atypical, but is an example to demonstrate that sometimes you have to think outside the box and not assume that you've ruled out everything, because patients can present with many reasons for anemia, and infection is one of them, and chronic infection can lead to multiple issues with organ damage, such as in her case. So patients who have severe anemia are oftentimes considered for a blood transfusion. So what are those indications for a patient who would require a blood transfusion? So a blood transfusion is indicated typically if a hemoglobin is less than 7 and the patient is symptomatic. If they're having severe shortness of breath, heart palpitations, lethargy, severe weakness, and so forth. If a patient is clinically stable and shown to have an iron deficiency and their hemoglobin is less than or around 7, they can be referred to hematology for consideration of iron infusions ASAP. Hematology can order an outpatient blood transfusion if necessary, if hematology feels that iron infusions may not be enough to help with their current anemia, which would save the patient an unnecessary ER visit. So after reviewing anemia in this presentation, we want to recap and talk about how to initially approach a patient that has anemia. So some questions to answer. Is the bone marrow suppressed? Is the patient bleeding now or in the recent past? Is there evidence of hemolysis? Is there a vitamin deficiency? Based on these questions, order the appropriate laboratory testing. If malignancy or organ dysfunction is suspected, order imaging to rule this out. Refer to specialists if necessary for further workup. If the cause is reversible, treat the underlying cause. And if you are still stumped, then of course, refer to us, refer to hematology. So when should you consult hematology? So indications for hematology consult include unexplained anemia, unexplained microcytosis or macrocytosis, a patient who is not responding to oral iron supplementation, a patient who meets criteria for IV iron replacement therapy, if there's a concern for malignancy-related anemia, if a patient has severe anemia with a hemoglobin of less than 7, and a patient with anemia of chronic kidney disease and persistent hemoglobin hematocrit of less than 10 and 30 respectively. These are my references to this presentation for your review. In this slide, I just want to take a minute to show my sincere gratitude to several people who are important in my life, and I would not be here without them. First and foremost, I want to thank Sharon Bess, who has been an amazing person in my life and was allowed me to present to you today, and was extremely supportive and encouraging throughout this whole process. I also want to next thank my wife and my kids who have put up with me with making this presentation for the past several weeks. Can't thank them enough for their support and love. I also want to thank my supervising physicians and my colleagues who I constantly go to for advice and discussion of anemia and oncology related information. And I can't thank them enough for their words of wisdom and guidance. And last but not least, I want to thank the two people that helped me get to be where I am today. And those are Dane Alonzo and Jim Hancock, who are both PAs where I'm originally from in Florida. They were instrumental in getting me into the PA profession, and they both worked in hematology and introduced me to the world of hematology and oncology, and helped me realize that this was my true passion and my true love that I want to do for the rest of my life. So with all those people, I thank you. And thank you so much for listening to this lecture. If you have any questions, comments, suggestions, any feedback, I would greatly appreciate it. Please email me in the email below. And thank you so much for your time.